All right, everybody, we're going to go ahead and get started here. Going to turn down the tunes a little bit. And we're going to be talking about the hip from the Orthopedic Conditions Manual. We're going to be going through basic intro and then moving on to other key options as well. All right, so go ahead. So beginning with here, we've got our Orthopedic Conditions Manual. You understand the layout of this text. Of course, all of your learning objectives are there. And like everything that I do, we are trying to have a systematic approach to make your learning easier so you can apply this for patients much more rapidly and not spend so much time studying. So we go through the anatomy to begin with, then we'll go into assessment and then look at our actions on a case-by-case or condition-specific pathology base. So to start with, you might even be aware of basic positions of pain referral on the body and around the hip. Things like TL junction pain versus low back and SI pain versus the hip joint itself versus hamstrings versus piriformis type syndrome versus the trochanteric bursitis or groin pulls. And of course, we can have other more serious ones like pubic stress fractures and other things like that, but just kind of a quick overlay of the pain referral patterns. If we go into a little bit more detail, I could pick anybody in this class and they could take me through all of the bones and bony landmarks of the ilium, ischium pubis, and the femur itself up around this region. We could also remind ourselves of different changes like coxa vera, increased angle, and coxa valga, decreased angle, more of a male type pelvis or angulation. And be aware that this anatomical variation carries forward into femoral anteversion and retroversion. Your femurs do not have to be the same shape. They might have different spins from one side to another. Progressing on from there, we can build out the ligaments, and you should know some key things for these ligaments. Of course, this is a discussion around the hip, so the ilio, ischio, and pubofemoral ligaments, but also right down here, your little buddy, that ligament to the head of the femur or ligamentum teres. We should be aware of that because that anatomy has direct application to certain pathologies in the hip. And of course, it's always good to review sacrotuberous, sacrospinous, iliolumbar ligaments, zygapophyseal joints, ligamentum flavum, and all that good stuff that would be up there as well. And if you're lost, we also have videos on the bones, on the ligaments, and we'll get into muscles in a second. All these videos you can find for how to palpate all of these structures and our special tests too. Of course, remembering, depending on the age of the client or patient that you're working on, that the femoral neck angle does change over time, and there's going to be a variation from male to female or even genetics, depending on what part of the world you're from. And as we go through those secondary ossification centers and we go from cartilage to full bone formation. Again, more relevant here for that slip capital femoral epiphysis, but we'll come into that in a little bit. So that will get you through the basics of the ligaments. Then we come into the muscles. And should you not remember the origins, insertions, and actions of all of these muscles, I would refer you back to your good buddy, the muscle manual right here, or again, we have videos of all of this content on our website to go ahead and review. But nice things to look at. You can see iliopsoas coming down into rectus femoris, all of that good stuff. We can see the layers again. So if you're looking at these pictures, one of the key things I'm trying to do is progress you through layers of palpation or layers of depth. So you go ahead and you start nice and light and superficial, and we begin out here looking at our most superficial layers, TFL, sartorius, all that good stuff. You get a little bit deeper in. Now you can see the adductors and quads a little bit better for rectus femoris. Take those away. Now you can see psoas a little bit better, the deeper adductors, obturator externus up here, and of course, vastus intermedius. And then taking that down as well, you can see the same thing on the gluteal region, going from glute max, peeling that back to gluteus minimus, medius, and then piriformis, and then the short lateral rotators, all the way down to quadratus femoris, your good friend that you remember. And the same thing onto the hamstrings. Excuse me, I actually quite like these pictures right here. They're excellent drawings from not H.V. Carver. This is Dr. Paul Richer, actually, absolutely amazing drawings here. One of the drawings that I like the best, though, this is actually from H.V. Carver and Gray's Anatomy, is this one showing us the orientation of gluteus medius to the greater trochanter, piriformis, obturator internus, and obturator externus. You can really see the layout for those muscles. Again, pretty tricky for students the first time they're learning it, or even doctors who don't remember it in practice very well. So I would encourage you strongly to go back and look at that information because we're going to be glazing over it here. But like I said, we've got hundreds of videos on this, or of course, the textbook content that goes with it as well. And once you know that, you can get into a little bit of kinesiology. You know what the normal range of motion is going to be for the hip. You also know the muscles that are activated with each motion that you do. You also know the joint shapes, resting positions, you know, the end feel types that we should see, Q angles as well. So you should know that they're slightly higher in females and lower in males, but that's old information there for most people. And then hip pathology, rapid review, differential diagnosis. So in 3 lines or less, they're all in 3 lines, I try and tell you what are the key things I have to know for avascular necrosis versus an acetabular labral tear versus DJD as a rapid review place for you to look for this information. Now, we're going to go into future videos with this and we'll break down each condition in more detail, but at a most superficial, foundational, fundamental level, these are the key things that you have to understand. And then I go through a full hip exam flow. And the reason that I made these, whoops, we'll go back this way. The reason that I made these is because I cannot remember all of this content. This is more than I have to be able to remember right here. So we made up a cheat sheet that is the exact same as the exam flow. And at the start of the assessment portion of our website and at the start of every portion in our books with the orthopedic assessment as a prime example, we go through in about 10 or 15 minutes how to do a detailed assessment, including detailed palpation, again, videos that show you all of that, range of motion to each action, myotomes, leg length evaluation, if it's relevant, separate video on that, pathology, neurovascular screens, and then orthopedic tests, key, well-researched, good quality orthopedic tests based on the pathology. So hip DJD versus lumbar radiculopathy versus hip flexor length versus piriformis syndrome versus instability. And all of that you can find together. And it would remind you even more so when you're into practice and in clinic and you have our fantastic chart forms that you can use as a cheat sheet or playbook to get you through some of this key content. So good information right there. Then we get into our palpation checklist. Again, that's just saying, hey, go to the website. We've got video on it. You would start off, of course, with active range of motion. Again, keeping in your brain, in your little thinker box, what am I actually activating? What tissue is being stretched and compressed? What are my potential pain generators and areas that I might want to focus my time on a little bit more? Then we can go into goniometry if you have litigative cases where you need more detailed information like that. Hip passive range of motion. Again, remember this, your assessment is therapeutic. The active range of motion can be therapy. The passive range of motion can be therapy. It gets people moving as well. You can stretch and move people in a lot of different directions, move them in directions they think they can't go gently and challenge their perception of what they believe is possible. Then we get into muscle testing. And again, there are detailed videos of each of these muscle tests. If you're looking for ultra specific pathology generators, I would refer you again back to the muscle manual for that as well. But remember your basics of the muscle testing and evaluation. Okay, one of our key things that we do. Good outcome marker, the muscle testing too. And then key orthopedic tests like a Scour test, Gainsland's, Ober's, or Patrick Faber's test, all of that good stuff that will help you more specifically isolate pathology in practice. And of course, videos and book support for that. Now, diagnostic imaging, not necessarily required all of the time, but we show you some basic layout of the imaging, how you would set the person up, and some key lines that you would use. These show up on board exams all over the place. Shenton's line, right there for skiffy. Klein's line, another one for skiffies, right? Slip capital femoral epiphysis. You can look at joint space narrowing for osteoarthritis. Non-uniform joint space loss for DJD is a very common one for us to see. And that will get you through the basics of the intro right there. So I'm just going to stop my screen share for a second.